Okay, folks, again, it is my pleasure to be here, and I'm really grateful to all of you and people who invited me here. Let me tell you right away that in this presentation there is very little scientific value. The story is, a couple of months ago, I was on a very long flight to Latin America, and I'm working for the UN. I'm traveling a lot, and I was on a very long flight, 14 hours, and the guy next to me on this flight was exactly the wrong guy to have next to you on a long flight, because he wanted to talk desperately, and I tried all my skills just to show him that I'm not particularly interested in talking to anyone, and then I gave up. And we got involved in a conversation, which was a big mistake that I made. And, and then I made another mistake, this time critical, when I answered his question, what do I do for a living? And that was it. And then when he heard drugs, alcohol, mental health, United Nations, all these kind of things, I saw he got really excited. And then in the next 4.5 hours, he tried to prove that what I'm doing is a total waste of time, that nothing works, and I'm wasting my time and everybody else's time. But he knows exactly what needs to occur to solve the problem around the world tomorrow, 9 o'clock in the morning. At some point, I thought he is psychotic. I'm a psychiatrist. But actually, no. But anyway, I was listening to all of these things. I'm on a plane, there is nowhere to go. I was listening and I was trying to make sense. I'm here anyway, I'm stuck with this guy, and fine. And then while I was listening all this nonsense, I got myself thinking that, folks, it's a real story, that I've heard these things before. This is not the first time I hear it. Again, now I'm going around the world, and I have meetings with policymakers, decision makers, prime ministers, all sorts of important people. And very often I hear the same statements, regardless of the culture, regardless of the country, regardless of anything. There is a number of things that I keep hearing consistently, time after time, meeting after meeting, from people who make quite important decisions. Things that are, to say the least, are inconsistent with what we know from research and what we know from the science in the beginning of the 21st century. So then I decided, after this very nice and long conversation with this guy on the plane, I decided to put together, to make a collection of most common mythologies and misunderstandings about the nature of drug use disorders, the nature of the treatment of this type of conditions, the most common mythologies that I've heard, and I'm sure you've heard many, many more. So again, this is not a purely scientific presentation, it's just my way of sharing with you what I've heard, and who knows, maybe you'll be, or you have been exposed to the same type of conversations. So let's go ahead and get started. And as a way of getting started, let me define what is a myth. A myth is it's a belief for which we either don't have evidence it's accurate, or we do have evidence it is inaccurate. Okay? This is what a mythology, at least operationally, the way I would define it. And the following is perhaps the most common myth that I've heard, and this is the societal expectations from us. What the society and the policymakers and the governments and funding agencies, what they often expect from drug and alcohol treatment. And what they expect is actually a very logical, quite nice, quite simple, and totally wrong model. They expect that you have a person at the front door, you have a person who is drug dependent, coming to your office for whatever reason, court mandated, voluntary, whatever. This person just came to you, and because you're so good in what you do your magic, medication, services, psychotherapies, motivational interviewing, all of the above, something else, so you do your magic, and at the end of this process, you have somebody who is not drug dependent. And this is what this is. I'm sure you have been exposed to this type of expectation. And this is so common and consistent. Again, this is logical, quite simple, and absolutely wrong model, and I will explain you later why. This is another very common mythology. Why should we treat them? They just made their choice. And the idea about making a wrong choice, how many of you have heard this from other people? That why should you treat these folks? They just made a wrong choice to use drugs. Please show me your hand. Okay, the majority of you. Nice. Well, let's think about it. The substance use disorders, drug and alcohol disorders, these are disorders with typically pediatric onset. People start using drugs around the age of 14, 16, 17, across the globe, all over the world. So this is a pediatric onset problem. Teenagers are typically not very good in making choices. I'm sure that all of you, when you were 16, all of your choices were correct. All of the risks were well measured. So you did a great job making right decisions at that time, but not everybody is like you. That's the problem, okay? Most teenagers are not very good in making choices. And the reason why is it so, if you look at the science, the way our brain develops is very interesting. Actually, the brain develops backwards. By the time the baby is born, the backside of the brain is already well functioning with some vital centers inside, in the backside of the brain. Over time, around the age of 12, 13, 14, the midbrain is getting developed. And the midbrain, the mesolimbic system, is the emotional brain. It is the brain. This is the part of the brain responsible for our ability to experience rewards. This is the brain that generates impulses. The impulsivity, in a large measure, is regulated by the midbrain. And around the age of 24, 25, under the best circumstances, without any disruptions, the frontal brain, the thinking brain, gets developed. So now it's quite understandable why teenagers, how many of you have teenagers at home? Okay, well, they drive us crazy, but that's the way they should behave. Teenagers tend to be moody. They tend to take risks, sometimes not well thought of. They tend to be very reward-prone, reward-seeking, and this is a normal behavior at that stage, at the time of the brain development when the emotional brain is well developed, but the frontal brain, the thinking brain, is not. And the thinking brain works like brakes. When the midbrain tells you, let's go, let's have fun, let's do something, because that will be really nice, then the frontal brain tells you, okay, come on, hold on. You remember the last time you did it, what happened? Okay, think again. All right? Teenagers are, even physiologically, are not capable to make significant choices. So the idea that the teenagers are using drugs because they made the wrong choice, definitely there is an element of choice, but the whole process is by far more complex, even physiologically. I'm not talking about environmental influences. By far more difficult than most people think. This is... Where is the laser pointer? Oh, okay. Well, this is exactly where the decisions are made. I don't know if this thing works, but no, it doesn't. It's all right. This is the distinction where the decisions are made in adults on the left and in teenagers on the right. The decisions are made by two quite different parts of the brain, the mesolimbic brain and the frontal brain in adults. All right. Some people just say why people don't stop using drugs. That would be easy. And there are quite common belief systems around the world. Many people believe that people don't stop using drugs simply because they don't know there is a problem. So the knowledge is missing. They don't know that there is a problem here. There is a pretty common belief system that people continue using drugs despite problems because they don't have skills to stop. So they know there is a problem, but they don't know how to stop. In criminal justice environments, there is a very common belief system that people continue using drugs simply because they don't care. Okay? Folks, if this is true, or in many instances a combination of these three things, have you heard this before? People use drugs because they don't know they have a problem, they don't know how to stop, or they don't care. I'm sure you have heard this before. Okay. Well, if this is true, it means that you absolutely don't need my presentation at all. Because the solutions are very simple. If knowledge is missing, give them knowledge. Put a bunch of people who use ice in a classroom for an hour. Tell them that it's bad to do. Well, just give them knowledge and they will stop, right? Okay, you will tell me, all right, Igor, you're a smart guy. Well, maybe skills are missing. Well, let's give them skills. Fine, good idea. Let's give them skills, how to write a job application and apply for a job. That will definitely do it, right? If they don't care, and this is why they continue using drugs, well, make them feel uncomfortable enough, put them in prisons, or, make them inflict certain amount of pain, and they will stop. They will start caring, right? So when we put people in prison, they should stop. And we all know how ineffective these approaches are. The problem of continuation of drug use is by far more complex than most people think. Okay. This is another very common belief system, particularly in people who work in prevention, that drug use leads to dependence. And it's kind of a logical assumption, but the truth is most of the teenagers who use substances will stop. They will not continue. Actually, the minority will continue and will get stuck with drugs. Most kids don't. They try, they experiment, and they will stop. The difficulty is to find out who is this kid in this classroom who is experimenting with substances will develop difficulties and potentially significant severe problems. The idea about treatment beginning, there are so many different perceptions. When do we need to start treatment? The readiness for treatment issue, have you heard of this statement? The patient must be ready for treatment to start treatment? There are all sorts of things flying around the treatment world. But the science is quite clear about it. The earlier we involve a client, in any kind of treatment operation, the more chances we give the client to succeed. What we have in the reality, lots of long waiting lists with nothing happens between the first interaction and the day of admission. And this is a problem because the longer we wait with the client, the less likely for this client to show up again for intake assessment. So we need to be creative and find I understand the long waiting list is a systemic problem, the funding problem, all of these things, I understand it. But we probably need to be creative. What will we do with this client during these 2-3 months of waiting time? Maybe we can get something done, at least something to increase the likelihood that this person will show up again. Okay. Another common belief or mythology about how long the treatment should be. Some people believe the treatment should be as short as possible to avoid life disruptions, which is kind of a logical assumption. Many people believe the treatment should be forever. And you know what? Frankly, I don't know the answer to that. The data, the outcome evaluation research is actually surprisingly consistent. Any treatment, regardless of the treatment model, any treatment shorter than 90 days gives you the same result like in never treated controls. What is the magic of this 90 days number? I don't know. But the outcome evaluation data is very, very consistent. So if we do any kind of intervention, it's a good idea to increase the length at least to 90 days. It seems like 90 days is the minimum dose of treatment regardless of the model that will give us any chance of better outcome as compared to never treated controls. I'm going quite often to low and middle income countries in Africa, in Asia, in Latin America, in Central Asia. And these are places with very limited resources. If you believe you have limited resources, believe me, you're fine. Trust me, you're fine. I'm going to places like Afghanistan, Ecuador, Kyrgyzstan, the countries with very low income, and really it gives me the opportunity to appreciate what I got going there. So, and in these places, particularly places with severely limited funding, I keep hearing things that they need to start developing treatment system because they have a significant problem. They need to start developing treatment system, and the place to start is to build detoxification programs. In most cases, the only idea that they have in mind is the more detox programs we have, the better it is. Believing that, for some reason, believing that detox programs are effective. If you look at the data, effectiveness of detox alone, if nothing follows. Detox sometimes is an important step, and it's a very needed step in many instances, not always. But if this is the only thing we do, detox, the effectiveness is zero. Our clients relapse within hours, not even days, within hours, if nothing follows. At the same time, if you look at even in the newspaper ads in the United States, pretty common, you see in significant and large, serious newspapers, you see things like 24-hour detox, I will cure you from opioid dependence with one injection in 24 hours. Have you heard these things? I'm sure they're all over the world. So let's be mindful. Detox is an important element of treatment. This, in many instances, a necessary beginning of a treatment process. But if this is the only thing we do, the effectiveness can be measured in hours, not even days. Okay. We got that. Have you heard this statement? The patient must be ready, the patient must be motivated for treatment, and if the patient is not motivated, there is nothing much we can do. Have you heard this? I'm sure you have. Well, let's think about it. The client's motivation is very fluctuating things. It changes in minutes. And in fact, the motivation for a client to do or not to do things depends on our behavior as caregivers, as treatment providers. So in other words, the client's motivation is our problem, it's not the client's problem. The motivation will change primarily, greatly, based on our behavior, the way we interact with this person. And if you look at the data, you remember the second half of this myth, that if a client is not motivated, there is nothing we can do about it. And I'm sure you have heard this before. If you look at the data is actually very interesting. There is a lot of studies. I will show you just two of them, two of the best studies I've seen. One is from the University of Denver, the state of Colorado in the US, on IV drug users, opioid drug users, 4,000 of them, who came to treatment centers for HIV testing. They didn't want any drug treatment. The only thing they came for was HIV testing. From the ethical standpoint, you cannot force people into treatment, neither you can deny HIV testing if they want it. So these 4,000 people have been randomly assigned. All of them got what they wanted. They got HIV test. But approximately half of them, during this testing, during the initial conversations, received a very short 10 to 12 minutes intervention from counselors specifically and very well trained in motivational enhancement therapies and motivational interviewing. Remember, none of these people, none of these 4,000 people wanted treatment. Here is what happened 6 months later. This is the group of clients who received what they got. They got what they wanted. They got HIV test and nothing else because they didn't want anything else. Injection, how many of them are abstinent, and almost a quarter of them are arrested. And these are the results in the clients who received the HIV testing plus motivational enhancement. Do you see the difference? Remember, none of these people asked for drug treatment. Here is another study from Johns Hopkins University, a very similar methodology. The study was done on women, all of them stimulant-dependent women who came to the hospital. All of these women were pregnant, and they came to the hospital for prenatal care. They did not want any drug treatment. They received exactly what they wanted, a half of them approximately. They received the prenatal care, but some of them received prenatal care plus motivational enhancement work provided by very well-trained people. What does it mean, prenatal care? This woman will show up once a month at a certain place, will wait in the waiting room, will do something, will sit there, read the book, and while sitting there, she had a conversation with a well-trained counselor. Results, just look at the differences in the numbers. How many of them have been tested positive for stimulants at the day of childbirth? Look how many, what was the weight and gestational age of the baby? Look at this difference. Take a look how much time they spent, all of these women spent in the intensive care unit and the cost of it. You see that even in people who are not particularly motivated, they are not seeking drug treatment, with some creativity and a little bit of skills, we can still do a lot of things. And these type of interventions are very cost-effective. Everybody is complaining about funding, and it's all over the world, and I certainly appreciate it. But you see, simple and relatively cheap intervention can give you an enormous cost saving right here. So apparently, a lot of work can be done even with people who are not particularly motivated for treatment. This is another very common belief that punishment, coercion, compulsion, pressure, criminal sanctions are necessary for our clients to get better. Have you heard this? Well, there is absolutely any evidence of effectiveness of compulsion or imprisonment alone, or any kind of criminal justice pressure alone. There is no data to support the effectiveness of this type of interventions in criminal recidivism and drug and alcohol relapse reduction. No data whatsoever. There is no single study to support it. Yet, actually, there is a number of studies suggesting, particularly if you place young drug users, people who are younger than 25, if you place them in an environment, criminal justice environment, and put some pressure on them, criminal justice pressure, actually we will make them worse. We are likely to increase the likelihood of criminal recidivism in this population. So it's not just not getting the outcome you're looking for, it's making people worse. Some of the clients are. Let's be mindful about it. This is what we know from the studies. The baseline, if we provide people with drug use disorders, if we utilize criminal justice pressure, we are getting below the baseline. You see the red square, meaning it's getting worse. We will increase the likelihood of criminal recidivism and drug and alcohol relapse. If we provide these people with meaningful treatment intervention, and I will be talking tomorrow about what type of interventions for what type of people, actually there is a chance that we will decrease the likelihood of repetitive criminal behavior, and we will improve their chances to succeed with their drug and alcohol treatment. What do we have in real life? Well, in some countries we have concentration camps and labor camps, and these people call it treatment. And I've been in some of them in several countries, and I had conversations with their decision makers. I'm not in a position to tell people what to do. These are sovereign countries. They decide for themselves. But I was very surprised when I've seen real labor camps for drug users, not even offenders, for drug users. And they seriously call this intervention, this operation, they call it drug treatment. Does it make sense to you folks? Am I making any sense here? Okay, I'm just trying to get some feedback from you. Okay, let's spend some time talking about this, and this will be kind of the end of my sharing. This is not even a lecture, it's kind of more sharing. Have you heard this? Treatment of substance use disorders is not as effective as treatment of other illnesses. In other words, what you do is not effective. This is exactly what the guy on the plane told me. What you do doesn't work, no treatment works. Well, let's think about it. I would like to make a comparison. Actually, a lot of data I'm using in this segment of this conversation is from the work of a very good friend of mine who I think is absolutely brilliant researcher by the name of Tom McClellan. I'm sure if you read the literature, you know this name. So this is a lot of his work, and I spoke to Tom and I told him that I will be using his data in some of his publications in this part of the conversation because I think it's very compelling and just brilliant. Tom McClellan. So let's make a comparison between addictive disorders, substance use disorders, and conditions like hypertension, diabetes, or asthma. Why these three? Well, because there is no doubt these are illnesses, right? You all agree with me? Okay. There is no doubt they're chronic. I mean, neither of these conditions are acute. It's not like a broken bone or infectious disease. These are chronic conditions. All of these conditions, diabetes, hypertension, asthma, and drug use disorder, addictive disorders, they are influenced by genetic factors, metabolic factors, behavioral factors, and environmental factors. Would you agree with me on that? Okay. And we don't have cure for diabetes. We don't have cure for some forms of hypertension, although we have very effective treatment interventions. And we still don't know how to cure drug dependence or alcohol dependence, but there are very effective treatment interventions available. Okay? Would you agree with me on that? Okay, let's take a look. So it does make sense to compare these conditions. In terms of patients with hypertension, how many of these patients do exactly what the doctor told them? Particularly at the beginning of treatment, when they were just diagnosed with hypertension. Actually, quite a few. How many of these clients, these patients, take the medication the way the doctor prescribed? Less than 30%. How many of these patients actually follow the dietary regimen, exercise, weight control, and other things? Less than 20%. How many of these patients are retreated within 12 months period? More than a half. Okay? Pretty much the same picture for patients with diabetes. More than a half of these patients don't do exactly what the doctor told them to do. Most of these patients never follow through with what the doctor said in terms of regimen, exercise, diet, and other things. How many of these patients need another treatment within 12 months period? Approximately a half. Okay? The same with asthma. Okay. If you look at the relapse factors in patients with hypertension and diabetes, you see these four. Studies are very consistent. There is meta-analytical research. Studies are pretty clear about it. These are the four factors, most typical factors for retreatment in patients with hypertension and diabetes. And look at these factors. Not the severity of the condition, not the severity of genetic predisposition, lack of adherence to diet, medication, and exercise, low socioeconomic status, low family support or any kind of environmental support, and psychiatric comorbidity. Now, take out the diabetes and hypertension and put addictive disorders, and you will see exactly the same risk factors, right? Okay, so they're very comparable. But at the same time, people, particularly decision makers, and funding agencies, people still say, well, your treatment doesn't work. Addiction treatment doesn't work because you see, this guy was in treatment, 6 months later he's using again. Again, let's think about it. Why? This mythology is so pervasive, particularly in the heads of decision makers. Well, because we evaluate these two conditions in a completely wrong way. We approach the evaluation of addiction treatment in a completely irrational and illogical way, and here is why. This is the typical treatment delivery strategy for acute conditions. When we have symptoms increase, you see this curve goes up. I don't know if this pointer will work. No, it doesn't. Anyway, you see when the symptoms go up, now that you have symptoms, and we provide people with treatment. As soon as the symptom severity goes down, treatment stops. Okay? If there is any next increase in the symptom severity, we will start treatment again. This is a treatment philosophy, treatment delivery philosophy that is quite applicable for acute conditions, for infectious diseases, for appendicitis, for broken bone, for conditions that actually do not require intermediate maintenance. And this is the philosophy of chronic care conditions, something that we typically do not use in addiction treatment field for some reason. Meaning, the more symptoms you have, the greater is the symptom severity, in our case, compulsive drug and alcohol use, the more intensive treatment we will provide. Then the severity will subside, the patient will get better, and from this point further, we need to continue our maintenance, recovery maintenance process. Can you imagine a patient with hypertension who came to the doctor's office? How many of you are physicians here? Any physicians? But you're familiar with hypertension, okay. A patient came to the physician's office, a patient with hypertension, the blood pressure through the roof. The doctor started treatment. Usually treatment is quite effective. Now the blood pressure is under control. And as soon as the blood pressure is normal, the doctor says, okay, your treatment is over, go home. Here's what you got to do, go ahead and do it. And the treatment stops. Can you imagine that? Well, in physical medicine, this will be considered as malpractice. Because we all know that hypertension is a chronic condition that requires long, probably lifelong maintenance, because otherwise this patient will get worse very quickly. So we need to continue intervention. But this is a very common practice in addiction medicine. We provide people with a single treatment episode, they typically get better, and we say, fine, the treatment is over, you go home, do this, if you won't call this number, go ahead and goodbye. Even think about the way we think about treatment effectiveness. Let's go back to hypertension example. A patient with hypertension left treatment, or the treatment was stopped for some reason. This person was fine during treatment, but now the treatment stopped, and 2-3 months later the blood pressure is high again. What usually policymakers say? Well, you see, you stopped treatment and you got worse right away. When you were in treatment, you were fine. So for policymakers, the relapse in this case is considered as evidence of effectiveness of hypertension treatment. When you were in treatment, you were okay, and now you are not okay because you are not in treatment. In case of addiction medicine, there is a completely irrational logic that I see it and I hear it all over the world. The logic is, you see, this guy had treatment and now he's using again, so your treatment doesn't work. In this case, the relapse is considered as evidence of ineffectiveness of addiction treatment. Do you understand the completely irrational logic applied to two very similar processes? So the problem is not with the addiction, the problem is not with the clients. In many instances, particularly speaking about this mythology, the treatment of addictive disorders is less effective than treatment of other chronic relapsing conditions in general medicine. This mythology comes from our societal attitude and lack of clear understanding what is the nature of the problem we are dealing with. And unfortunately, many of the decision makers all over the world, in the USA, in low-income countries, in Africa, in Latin America, a lot of decision makers are not well educated. These are nice people, they're very talented people, but they're not familiar with the level of science that we have now in the beginning of the 21st century about the nature of addictive disorders. So one of our functions is to educate them, to provide special trainings for policymakers, for funding agencies. What is it that you are talking about? Everybody's happy, or not happy, but everybody is talking. It's very common now to talk about outcome-driven funding. Do we have this in Australia? Outcome-driven funding. That's not a bad idea, but this will become a nonsense unless you have a very clear understanding with the funding agency what would you consider an outcome. It's really important conversation to have. Because if you think, you and the funding agency, if you consider two different things as good outcome, you will never get funding because you're talking about two different things. Are you with me on that? Okay, nice. So going back to the effectiveness of our treatment. In case of hypertension, let's use this example again. People consider treatment effective because when the patient was in treatment, the patient is likely to be fine. So we're looking at the time during treatment. In case of addiction medicine, no one cares that while in treatment the patient is likely to be okay. We just ignore this time of treatment. And people say, particularly decision makers and policy makers, they say, your treatment doesn't work because your patient is using again or drinking again. Exactly what the guy on the plane told me. What you are doing is a waste of time. You give people treatment, now they're using again. This is an irrational logic, completely irrational logic. This is not the way to evaluate the effectiveness of our treatment. And in fact, treatment of addictive disorders, if you look at the long-term outcome research, treatment of addictive disorders, in other words, the number of people who went into sustainable remission and they maintained the remission 3-5 years after the initial acute treatment episode. This number is pretty much the same like the number of people with hypertension and diabetes maintaining remission and relatively stable level of psychosocial functioning 3 to 5 years after the initial diagnosis and the initial treatment. Yes, probably there will be some bumps on the road because we are dealing with a chronic and relapsing condition. It's not because our patients are crazy, mad, or criminal, or neither it's because you're a bad therapist. No, this is just the nature of the condition, exactly the same way like in patients with hypertension or some forms of cancer or diabetes. One size doesn't fit all. There is no single treatment. Our clients are different. Our patients are different. They're all different. Actually, probably the only thing they have in common is that they use drugs and alcohol. Everything else is different. There is no any evidence that a single treatment can help them all. This is why we need a continuum of treatment interventions, including harm reduction interventions. Harm reduction interventions are quite effective for a substantial proportion of people with drug dependencies, and they're quite effective as long as they are not provided in isolation from demand reduction. If harm reduction is a part of the continuum of care, that would be wonderful because many clients respond well to harm reduction approaches. Harm reduction alone, forgetting everything else, is something that I would have significant problem with. In terms of the now, again, all over the world, particularly decision makers are looking for evidence-based practices, which is not a bad idea. We don't know everything, but we do know quite a lot. And we have quite a lot of research generated, particularly in the last 20, 25 years, both genetic, biological research, magnetic science, and environmental and behavioral science. We do know quite a lot. But when we talk about evidence-based practices, let's remember that the science is written and is done in different ways. There's some scientific evidence coming from well-done studies. There are some studies with very questionable methodology, and particularly when you're thinking about significant decisions, to use public funds for a certain type of treatment or not to use public funds for treatment, and certainly policymakers hopefully will take a look at what do we know from research, and hopefully they will take a look at the research that is well done, because there is a kind of, there is a relationship. The better is the scientific methodology, the less likely it will make us feel good, and vice versa. Science that typically makes us feel good is done in pretty bad methodology. So when we talk about evidence-based practices, generally speaking, it's a very good idea, but let's make sure that evidence have different strength, like in court. There is evidence beyond the reasonable doubt, but there is some kind of evidence, but nobody will get a sentence based on that. So there is different strength of evidence. Let's use the good science in our decision making. Let's remember that the science, addiction science, is a developing science. What we believed in the past is not necessarily what is supported by research now. And staying open-minded is very, very important. At least it happened many times to me. What I believe, I am in this business for more than 25 years. What I believe works, actually there is no evidence. Science does not prove it, it does not support it. And something that I thought is a total nonsense, well, apparently it's not. I was mistaken. It does work, at least there is some good data to support it. So let's stay open-minded, and definitely we need to utilize science in every clinical, political, and financial decision that we are making. Many of you are probably managers, you manage programs or organizations. Everything we do should be based on some level, acceptable level of science and acceptable level of evidence. So the evidence-based science promotion is one of our functions, certainly one of my functions around the world, and this is what I'm trying to do. But going back to the guy on the plane, in addition to evidence-based promotion, I think it is quite important to do something that I refer to as nonsense reduction. So in addition to promoting something, let's reduce the amount of nonsense that is going on around the world in the field of behavioral medicine and addiction treatment. And I really hope that my sharing with you made some sense for you. Again, I told you it's not going to have any significant scientific value, but this is some of the common things that I've heard, and you probably have heard too, And it would be nice to prepare ourselves next time we hear these kind of things, to be able to talk to particularly policymakers and not to argue with them, but rather to empower them with good level science, with good level data. And who knows, maybe they will reconsider and they will make a different decision. This is my email. I have a bunch of my business cards right here on the table. If you want to share with me something, I'm still here today and tomorrow. If you want to share with me something through email, please email me. I'm typically good in responding my emails. Again, thank you very, very much, and this is the best slide of all.